and it is a talk about pain and a digital pain textbook, and which I have no knowledge of to date and am looking forward to hearing about. Before I hand you over to Peter, who's going to just make further introductions, anybody who wants CPD points, I'm going to put my email address in the chat bar, and you just need to email me your CPD, your HPCSA registration number, and nothing else in a email, and then I will arrange for the CPD points. So on that note, I'm going to hand you over to Peter. Peter, take it away.
Thanks, Jeroen. Yeah, I just wanted to quickly make the introductions, although I think most of you probably know Romy and Joe, who are going to be doing the bulk of the presenting today, and then we will open up to the floor to discuss. So Romy is a physiotherapist by trade originally, and is now the head of, I did look it up earlier, she's basically the pain guru of UCT and has made herself a niche running interdisciplinary pain, and has been the primary mover to this book that we're going to talk about. Joe I know more about. Joe is a paramedic by profession and is a master's graduate of our program, and has now put on many different hats, from pain to simulation to all sorts of things. So yeah, welcome to them both. I'm going to hand over to them. Will you guys share your screen?
We will share our screen. I noticed everybody diligently turned their cameras off, but you know, there's nothing worse than talking to a blank computer screen. So Peter, please keep yours on. And anybody else who wants to give me some visual feedback, that would be really appreciated. Thank you, Karina. So thanks for joining us, everyone. We're really excited to tell you about our book, which was published just over 6 weeks ago and has had 4,400 downloads to date, which we're quite excited about. Understanding Pain, Unravelling the Physiology, Assessment, Management of Pain through South African Stories. So what is this all about, and why do we think it's important to tell you about it? Apart from the fact that many people in this room collaborated and contributed to the book. So we got funding for this project from the International Association for the Study of Pain, Developing Countries Education Group. They generously gave us $10,000 US, which when you convert to rands, you can do quite a lot with. And we invested that in working with an amazing designer and making sure that our book is not just factually useful and correct, but is also eye-catching and engaging. So that's the first people we want to acknowledge. We also need to acknowledge some amazing people who went through incredibly challenging, painful events in their lives and trusted us with their stories and have told their stories in the book. And then, of course, we want to acknowledge many of you in the room who co-authored with us, and an entire community of people across this faculty and several other faculties who contributed to the book. Anyone else we want to acknowledge there, Joe?
No, I'm sure we'll remember at the end.
Just Joe, because Joe's the one who made this actually happen. This was an idea in my head, and she pushed me along until it happened. And that's an important thing when it comes to writing a book, is to make sure you've got someone to make it happen. So why did we go about writing an online open access textbook about managing pain in South Africa? So for those of you who aren't familiar with how we understand pain, pain really is the ultimate biopsychosocial construct. It's actually to the point now where I'm talking that pain is socio-psychobiological. It is all about context. You have all cut yourselves at some point in your lives and not noticed it, had no pain until somebody pointed out to you that you were bleeding. And it's only when you look at it and you see the blood that it might have then been painful, stung a little bit, and that motivated you to go and wash it and put a plaster on it, okay? Pain is all about context. Something may happen to your body and not be painful until your brain consciously interprets this as being a dangerous situation. So in order to treat and manage pain appropriately, we have to make sure that we are teaching the next generation of healthcare professionals to understand the importance of context and to understand the socio-psychobiological framework of pain. And there isn't a textbook available out there to teach pain in this way. So this is something really new, is to be teaching pain in a structured way with foregrounding people in their context. Context counts. And context really counts in Africa because our context is different. So what pain textbooks are there are Western, they're weird, right? So they're from Western educated, industrialized, rich and developed countries. And a lot of what they prioritize in those textbooks is not relevant to our environment. To manage pain effectively, whether it's acute post-trauma pain or chronic pain, it's got to be person-centered. And something that we had noticed in teaching materials that we had looked through before writing this book was that however much people talk about the need for person-centered care or patient-centered care and how important the biopsychosocial view was, the minute we got to textbooks and teaching materials, instead of it being centered on the person with pain, that person became objectified. We immediately kind of stepped back into the old school thing of Mrs. Jones is a 35-year-old female who lives in a resource poor community. Like she's some abstract, objective co-star of the disease, of the injury. And what we wanted to prioritize in this book was the people and their context being central to everything that we do in this book. And so nowhere in this book do we talk about patients. We talk about people with pain, and everything is person-centered and directly contextually relevant to living and working in our environment. This book is designed for our students who are going to be working in our context, that they have the tools that they need to be engaging with people who are suffering in South Africa. So I'm going to hand over to Joe, who's going to tell us a little bit more about the nuts and bolts.
Well, I think one of the things Romy is skirting around is this pain book really started as both of our own stories. So I was a patient in the chronic pain clinic here at Curtis Gear, and it took me a year to find help because I just couldn't find anyone who wanted to understand my pain or listen to me. And all I was offered was increasing amounts of surgery and fusions, when in fact, no one believed that I was actually in pain. And so I think it was in 2017, and when I was discharged, I made Romy a promise. And I said, one day we're going to find a way to change the way that other people are educated and the way that they speak to people about their pain. So that's kind of really, I feel like, where this journey began. And I think that the pain statistics in South Africa are really terrifying. The idea that 1 in 5 people in our country live with chronic pain and how few resources there are to teach other people about it, just is kind of dumbfounding. So what we're hoping is that by writing an interdisciplinary book with people's stories at the center, we're able to change the way, hopefully, a generation of undergrad and postgrad healthcare students from every context learn about the way they talk to people about their pain in particular. We wrote the book in 6 parts. So we start at the nuts and bolts of pain and try and unravel kind of where pain comes from through physiology, some core principles in assessment and treatment of pain. And then we go through contextual case studies surrounded by sort of centered on patient stories in primary healthcare, chronic pain, pre-hospital and emergency care, and finally perioperative management. Section 6 is our resources section. So we provided educators with some printable resources that they're able to put up in their classrooms or share, and things that we hope help as teaching resources. So what does the structure of the book look like? Well, it's the word person-centered is something that we've stuck to, and we're trying not to say the word patient because we think it's a disempowering kind of thing. We'd rather talk about person-centered care, and to the point where we didn't edit some of the patient stories, and so people keep asking us, did you mean to add this mistake? And yeah, I want you to hear the person's voice on the page. I think Romy has talked a lot about what contextual resources means, but I think talking about the collaborative work is really interesting. So one of the things that we struggled with as we wrote the book was that a lot of the collaborators that we invited actually quite struggled to write around the patient stories and to write in plain language. We really encourage colleagues who are thinking of writing something similar to consider how your reader would like to read your book, that they would like to read it in a way which flows. Collaborative means that we invited as widely as we could from as many disciplines as we could, ranging in context from rural to tertiary, and as hopefully across lots of interdisciplinary spaces as well. So what do the chapters look like? So I'm just going to show you what the emergency and pre-hospital chapter looks like. We start with an introduction where we introduce some core concepts in that area. In the pre-hospital and emergency pain section, we talked about overcoming barriers to assessing and managing pain in the emergency setting. And we really tried to orientate a lot of what we wrote around encouraging solutions rather than just naming the problem. We then move into some cases. So we had a child who was burnt, who tells her story both in the emergency care, and then we follow her through into the perioperative section. We had someone with acute abdominal pain, pre-hospital polytrauma, and we wanted to make sure that we had included a diverse range of patients, and so we talked about neck of femur fracture in the elderly, which you'll hear about from Peter shortly. We then, every section has a conclusion where we hope that we've kind of condensed the core messages into 1 or 2 pages and provided some additional resources for further reading. We're really proud mainly of how engaging and vibrant we think the book looks, and we hope that it entices the reader to keep reading more. We had the privilege of having some funding and the opportunity to create some really lovely images and illustrations throughout the book. And so you won't find a lot of lists, but you will find a lot of graphics that we think orientate the story around something that is more exciting for a reader. We also chose a different color for each section. So you can see here that green is for the primary healthcare section, purple for chronic pain, light blue for perioperative care, and the darker blue is from our understanding pain section. We use deep dives, and don't miss this, to illustrate points that we wanted to make sure the reader was able to take out from our work. So the deep dives were taking concepts that we wanted to kind of explore a little bit further, and don't miss this boxes were for what we believe to be really core messages, things that we thought, even if the undergraduate student who had no understanding of pain just read our don't miss this, they would take our core concept home from the chapter. And lastly, I think that one of the things that we got an opportunity to do was to bring people who teach and understand pain in different ways together and create some really lovely images like the one on your screen, explaining when pain goes from acute to chronic. And I thought it was really fascinating how even people who were like established teachers in this area suddenly went, oh, light bulbs have come on for us. So, and the illustrator did a really lovely job of helping us take some of the things we had in our mind and putting them onto the page. So encouraging things like how do we sort of cross over between lots of different concepts into an image that people can use for teaching. And we had the opportunity to kind of pull together lots of concepts into things like what you can see on your screen here is non-pharmacological treatment of pain, the EECP of pain, environmental, emotional, cognitive, contextual, and physical elements that we as healthcare practitioners and healthcare workers can care for, which we thought was a really exciting thing to be foregrounding instead of just talking about what we're normally asked about, which is the pharmaceutical care. So that's a little bit about our journey, and I'm going to hand over to Peter to talk a little bit about the case more in depth.
Okay, thanks, Romy and Joe. I think you've both undersold yourselves quite a lot. Yeah, specifically, Joe, you said that this was for healthcare students. Every time I open it up and look, I learn something else. I think this is very much something for all professionals of all levels to learn from, to use as a tool for our students maybe, but for ourselves as well. So I wanted to start by mentioning the FACE authors, and I feel like I've missed a few, but some of them on the call, so take a bow and congratulations to all of you. But yeah, it does span across FACE, although I was a bit alarmed to find that palliative hesitating because it's got a longer name, but you know what I mean, palliative medicine is not in here, so there's definitely a gap. What I wanted to do was to just, you can, next slide, was just to walk you through one of the cases, just to give you a bit of an idea how the book works. For those of you who haven't had a look at it yet, I found it quite gripping and almost sort of went through it from cover to cover, just enjoying the stories and not enjoying the stories. As I understand it from the brief and from the very first story, which you can go to the next slide. The very first, even the next slide, that's, we've sort of talked about that. Sorry, you can go back one. This is the problem of not. Yeah, as I understood it, the brief was to find cases that are controversial and make you think, and where sometimes things all went right and sometimes things went wrong, and not just to use them as a critique for how badly we do it, but also that sometimes go right. And then just to highlight on this section just how multidisciplinary it was, we've got emergency care, pre-hospital, we've got quite a few emergency medicine specialists, we've got orthopods, pediatric intensivists, burns, physios, nursing, and from across the country. And this case we're going to talk about actually came from KZN. So I feel like it did tick all the boxes we talked about. Okay, next slide. These are the five emergency cases. I think we have to mention the acute abdominal pain because that talks to the first case that we've actually already published in, and it talks to the patient being Romy herself. There, I've piqued all your curiosity that you'll go and read about it. And it also talks to a very multidisciplinary approach and going back to fix the problem. So Romy very much picked up a problem in one of our local private hospitals in Cape Town. And as I understand, she's been back many times and run workshops and re-educated them and told them how they should have managed her. Okay, next slide. So the format of each case study chapter in the book is fairly similar. They all start with an introduction, just telling you the basics of the case, the epidemiology of this condition, how often it occurs, and then a deep dive into the mechanisms of pain, and a lot of detail and kind of theory there, but intertwined with the case. Then pain assessment. So any of you who've delved into pain know that the two angles are assessment and management, that we're all poor at both. And pain assessment has got a fairly standard approach, which the textbook tries to put across. Then the management and lessons learned and conclusion. And in between, as Joe said, there's little boxes giving you extra information. Next slide. So just to tell you about this case in a nutshell, I think it's probably fairly familiar to most of you. Elizabeth is a 72-year-old who lives in rural KZN, and she single-handedly cares for her two grandchildren. This is a real case. We had an MO in KZN who spotted the case for us and went and interviewed the mother and found all the records, so it's completely real. So Elizabeth had a fall at home. A lot of pain. She had a previous fracture and was on crutches already, and she was taken by a neighbor's bakkie to the nearest CHC. the CHC, she did some waiting. She got some sort of pain injection. I'm not sure if we ever worked out quite what. Could have been Voltaren, could have been pethidine, who knows. And she had a bandage put on and expressed just how scared she was at that stage. She then was referred and had an ambulance she waited a long time for, and then had a long bumpy drive in the back of the ambulance with a lot of pain. Whatever the injection was had worn off. And again, she expressed that she was very worried about what was happening and what was happening to her grandchildren. She then got to hospital and she was triaged. She triaged orange and got some quite decent IV analgesia, but waited a while and was then seen by the orthopods, moved on to some oral analgesia. And at the time we interviewed her, it was 48 hours later and she was still waiting for theatre. So you can see all the gaps and the angles from every discipline, every time span where we could talk about pain, where we did. Yeah, next slide. And then I'm not going to dig into the details, but just to give you little snippets of what in there. There's a lot of detail on the mechanisms of pain, all the different levels. Next slide. This talks about the OPQRSTUV all the way through system of assessing pain. And I know it's small, but just to look at the columns, you can see there's guidance here on what questions to ask, something about explaining her pain, and then how we can interpret that information, which I learned a lot from putting it together and reading it. Yeah, next. And then we dug into the management, and particularly the non-pharmacological management, which I think we're all especially bad at, and the things that could have been done better and were well done in this case. The pharmacological approach, trying to look at some alternative things and looking at them from every angle of the journey, from the clinic to in the ambulance to in the EC and in the ward. Those are some little screenshots of some of the blocks with extra information. Our next slide. And the lessons learned from the case. And in a nutshell, we said pain management is challenging. It does affect the outcome, to highlight some of the options, and communicating with the patient, because that was kind of what came out intertwined with the patient's story, that there was not a lot of communication with the patient about what was going on. Next. And that was the conclusion, which is fairly similar across cases, but has kind of little contextual bits about it. Okay, next slide. So yeah, that was kind of running you through a case. We hope that most of you have opened it and certainly got the link. I'll share the link now. I was waiting not to distract you all from listening to us. Yeah, I think we want to hear from you, what you all think of it, how we can best use it, and what the gaps are particularly. As I understand, this is an open-ended project and we're looking for new chapters and authors.
Thanks, Peter. If I may, I just wanted to come in on the palliative care conversation. So we struggled to include a palliative care story sensitively, because we partnered with patients and got them to write an informed consent kind of contract with us about how their story would be used. And so we collaborated with Katja Evans, who works a lot in palliative care and emergency medicine, and wrote a deep dive in palliative care in the introduction to the emergency medicine section. Any suggestions for how we can improve that are greatly accepted.
And I think this was one of the big lessons we learned in writing this book, is how to respectfully partner with and collaborate with our patients, with the people with the lived experience of pain, how to engage with them as real partners in this project. And it was really interesting how often some of our healthcare professional colleagues found that challenging, the thought that what they were going to write about the case would then go back to the person that this was about for that person's final okay on the chapter. And that for me really highlights some of the kind of ingrained hierarchical, perhaps not person-centered approaches that we often might hold in our healthcare practice, in the way that we engage with our patients in a patriarchal kind of power dynamic that often comes through.
Yeah, and Peter mentioned Romy's story in the emergency care section. You can read my story in the chronic pain section.
Yeah, we're both there.
Renee, your hands up.
Yeah, I think the palliative care story is a very important story to include in any pain story, and especially because most of the pain actually that we are seeing in many of the hospitals, etc., have a huge palliative care component to it. If you think about seeing up to 10 to 14 referrals just in Groote to a palliative care team every day for pain. And I do think it's also how we are working very closely with the post-operative teams, and how you move from a sort of acute pain situation into a chronic pain, into a palliative care pain situation is a very important component to capture.
Thanks, Renee.
So I'll leave palliative care alone, but I think the other gap potentially is sports. Karina and Jeroen, surely there are endless sports cases you can bring in. And my closest experience with pain, which Jeroen helped sort out, was a lumbar disc. There's lots of those you guys see.
I think I've been, because I'm Jeroen's my supervisor, I've been mistakenly put in sports. I'm more physiology, chronic pain, pelvic. So we can speak sporting groins if you want, but get Renee Naylor on. She can tell us about the rugby players.
Okay, sorry about that. Yeah.
So Karina is a co-author in one of the chronic pain chapters on managing chronic pelvic pain. But yeah, I mean, Peter, when you asked me about sport a while ago, I felt a bit bad because that is where I started my career, right? I started my career as a sports physio running onto rugby fields. And I think the opportunities for new sections in this book are endless. There isn't a field of healthcare that doesn't have to encounter and manage pain. So we could, we could build this book for a century to come, and add stories to it. But I think some of the key messages that are in the book, the basic messages about how pain is contextual, and that the basic tools on the assessment and management of pain, any healthcare professional that engages with those, I would hope would be able to translate them into their context in one way or another. But of course, having somebody's story really makes it, in your face, and you see how to translate it. But I think, there's just about every aspect of medicine could have their own section here. And ultimately, that's something that I would like to see us moving towards, because we need to be seeing pain mainstream throughout everything that we do, rather than, send it to the pain guys, they'll sort it out. I think Renee would say that, we should be mainstreaming the principles of palliative care through everything that we do. And similarly, that understanding pain and mainstreaming pain through everything that we do is just going to make everyone better clinicians. So people who want to contribute, who want to build on this framework and take this as a model and then build their section. Essentially, a section is a mini book within a book. 4 or 5 chapters isn't something to be taken on lightly, but I think there'd be value in doing that going forward. So I invite everybody to join us on this. It's fun. It's fun.
Maggie, your hands up, go ahead.
Yes, I just want to congratulate you guys. This is lovely and beautiful and very useful. I'm going to show this to all my students. And then I'm actually putting my hand up to help write for the palliative care pain things. So if you guys don't mind and chatting to me later, letting me know how I can help with this writing, I think this is the kind of thing that I could actually do, because it seems that it's in a easier language, more easily understandable, which is my side of thing. It seems to be less academic language, so I'm better at that side of things.
Thanks, Maggie. We've achieved that goal. We wanted to write it in accessible, engaging language and not, academic speak that makes you fall asleep by the time you get to the second paragraph. I think that the key thing with anybody who wants to partner with us in this section moving forward, the really challenging and the most important part is identifying the person and their story. That is what everything is built around. So, a palliative care section is going to be enormously valuable, but the enormous challenge is going to get people who are willing to tell their stories, and getting someone to share their story when they're at such a vulnerable point in their lives is going to have to be managed really carefully.
May I use family members?
We've used ourselves, right? It's like
No,
we told our stories. So
no, just because I've got some excellent patient cases, but most of them have obviously passed away, but I'm still in contact with some of the families.
I see what you're saying. So yeah, certainly, with the child's burn case, we have the little girl and her mother telling the story. And there's certainly value in that. But so I think it could be managed. But that's really the key thing, is the person's voice is central throughout this book, and we want to hold to that. Really important. Thanks, Maggie. Klaus, did you turn your camera on because you're going to talk to us? Yes.
I want to also just echo my congratulations, and I was thinking about the approach you used to develop this book or series of books, and the centering the patient or person experience in this, and in a way that very mature, vulnerable position you've placed yourself in as authors. And I'm just thinking, we always talking about all the ways that we need to be transformative and real and grounded and authentic in the way we do things. And this comes as a really wonderful example of how to practically do it. So I'm really, so obviously that's a big wow and a thank you and appreciation from my side. But I'm also thinking about your reflection on this journey that you've been in. As obviously this journey is ongoing, as you've alluded to, and there's more to come. Your advice maybe to young emerging scholars or academics who are clinician scholars who have this desire to also make a knowledge contribution and to strengthen the services, which we're all about, and making sure that the experience that our the persons visiting our facilities are enhanced through mechanisms like this one. Because I'm sure there's other avenues or directions or topics that are equally pressing, and I'm just wondering how one can learn from your experience to also think about what are the other things that we can do similarly. So that was maybe your advice or guidance to emerging group of scholars. Where do you start, type of thing? Putting a open source book like that together. And then the other part is maybe also looking at how one can not formalize the learning, but take the learning forward. So to say, are there ways that one could, how you envisage maybe this could be used for team-based conversations or facility-level conversations, like in a M&M. I'm very sure that, or patient safety incident, there might be things that come out like this that's really resonating with one of the stories that you have been sharing, and how that could be incorporated into capacity building efforts at a facility level. So yeah, this is maybe those two questions, and I'll I'll pause there. Thank you so much.
So for anyone who'd like to come to our workshop next week, Wednesday evening at the Teachers Forum, for the first 45 minutes, we'll talk about the pain textbook, and the second half, we'll talk about how to write your own, ranging from so we divide it into before, during, and after. So ranging from finding funding, how to budget, how to plan, how to manage your writing process. And then your dissemination plan. So I think one of the things we're challenged by is making sure that the book doesn't just sit on the UCT website. So any advice and help in disseminating it is very, very helpful. One of the lovely things about having the online book is that as long as we keep sharing the link, so we're due for an update. There's been some inputs from others who have seen some things that we need to add in or change. And we've managed to get into the People Development Centre for the Western Cape government, and I'm working on getting it into national. So I think those kind of things, if you're planning a book, don't just plan the book, plan how it's going to be used. As the first bit. And then I don't know if you want to answer the second bit.
No, I want to chip into the first bit though, because so I think one of the things that
are you going to say have a full-time editor?
No. One of the things that I was going to say in terms of advice to young or others who want to contribute and write books, write material that are important for training the next generation or important for spreading the word. I think something that we were cognizant of, like right from the beginning, right from that very first paper that we wrote, which was on my case, of doing this differently, of recognizing that as Africans, storytelling is fundamental to our culture and how we teach and learn it through storytelling. It is so much of who we are. And why not embrace storytelling in our educational materials? Instead of trying to create educational materials that look like educational materials that come out of Europe or USA or whatever, create our educational materials engaging in the way that we engage with each other face to face. So stop trying to create materials that mimic stuff that comes from other places in the world and create our own and put your stamp on it and make it African, make it ours. And I think that's something that we really held on to. And I mean, at the beginning, that very first paper, I really had to convince Peter that we were doing it this way. That it was different, and many of our co-authors found it very challenging to do it this way because it's not the traditional academic Western writing approach, but this is how we engage, and embracing that, and look at how inviting and everybody's enjoyed reading it. And I mean, since when did you hear anybody say they enjoyed reading a textbook and they actually read the whole thing? Nobody ever tells you that. It's like, oh God, I'm going to read this book, So I think being comfortable with doing it our way is a message I would give young academics or others who are wanting to develop material. Be comfortable and confident with doing it our way is really important. Yeah. And I've forgotten your second question, Klaus. What was it? What?
So it's in a way linked to what you've just said is about how do you use this material, this book to strengthen the services, maybe build capacity, have inform learning conversations in health facilities and so on. Yeah.
So I think one of the things that Peter highlighted is that in the book, we didn't just choose cases that were a disaster or choose cases that were good. We've got a mix of stories of things that went well and things that went badly. And all the way through, we've held with the non-judgmental, this is what happened, this is what we could do better. So I think using the book as a model of it's okay to be vulnerable, it's okay to celebrate when you've done things well, but you could still always do them better, and engage with humility when things have not gone so well, and how do you move forward. So I think that's something that we've held all the way through. And then I would like that. I think that the model we've used for every chapter, which Peter's taken us through, so this is who the person is. It starts with their voice, not Elizabeth was a 72-year-old. It's Elizabeth tells the story. Okay, start with the person in their context before we move into their biology and what's wrong with them. Okay, and then be methodical. So all the way through the book, we've tried to be very methodical in the structure and the approach. Okay, so what do we know about this condition? What's the physiology? Analyze the physiology. How do we assess this person? Methodically. Okay, now we've got all of that. How can we treat this person? Or how did we? Or, how do we reflect on it? So just that very standard methodical approach all the way through, I think is, you could start with a team of using a case from the book of saying, this is the methodical approach we're going to use for reflecting on patients that we've engaged with. Let's use the book as a model. And then now for the next patient that we're going to reflect on as a group, let's follow the same steps as a methodical approach all the way through. And I think that's what's really useful. Something that we know with pain management is that when people present with symptoms, we're often taught a structured approach of the patient with chest pain or the person who's short of breath and coughing. But pain, people somehow don't get taught a structured approach. But in the book, we've given people there's a structured approach of how to think methodically about this so that you don't miss opportunities to make a difference. So those are some thoughts that I have about how you could use this moving forward. Peter, do you want to chip in on that? I'm sure you've had lots of thoughts about this as well.
Sorry, who are you asking?
You. I was asking you. As somebody who's collaborated with us from the very first case that we did.
Yeah,
thoughts
I
about how to
completely
integrate
agree.
this.
And it was hard to find those cases. I thought I was quite well networked, and I put the word out that we're looking for a case like this, and we'll give you authorship, we'll help you. And it was quite hard to find people, and I think it was the two of you who actually found most of the cases. And yeah, I think when Maggie said using family members, that was kind of the fallback, that we all know someone who's had this, but we were really trying to get a diversified patient group from representing all around the country in all sorts of different contexts. And yeah, I think you've done well with that. I think we can all picture that case in deep rural KZN and how it worked out getting him through to a hospital. But if we were reading an American textbook, we can't picture that, and we can't place ourselves in there. Yeah. Okay, I'm not seeing any other hands. Just one other thing for you two to tell us about is this UCT online competition prize award. Update us on that.
Yeah, so we were nominated for the UCT Open Access Textbook Award. It's under review at the moment. So if you haven't downloaded the book yet, go ahead and download it so that they show that it's being used. Yeah, it's under review. That's all we know. So yeah, we're going to win the prize. If we do win the prize, it's a 30,000 Rand prize, which we will then use towards the next sections and further development of the book and the website, and possibly printing paper versions to make available. Something I would really like to do is that there are many rural sites, teaching sites, which don't have good internet access, and it would be great to have a paper version of the book available in those sites for people to refer to. Yeah, so to broaden the reach. But yeah, it's open access. We want it downloaded, used, integrated, talked about. 1 in 5 South Africans is living with chronic pain. 80 to 90% of people who get admitted to hospital are in moderate to severe pain. We need to be paying attention to it and doing something about it. Anything else
I
on
don't
the
want to take
prize?
away from
No?
your last words, Romy, but yeah, I very much echo what you say about the paper version. We have for 10 years been putting out an EM guidance fat paper textbook, and we desperately hope people would transition to just using the app and just using it online, but they want that book. So and I see them in the emergency centers. I see them tattered and pulled apart and chained to the table. People like things in paper, so I think that would definitely be something to aspire to.
Yeah.
Yeah. Okay.
That's where we are.
Thank you both for your time. Please, all of you, go and have a look in the book and use it, share it. And thank you to the authors who joined. Some of you have quietly just produced your stuff, like Nkebo, one of our registrars. Thank you. Thanks for joining.
And please, when you share it, please share the link so people have to download it themselves. Don't just share the PDF because it is getting updated all the time, right? So make sure people download the latest version. Cool.
And I hope we haven't stood on toes, because I know there's a few more FACE seminars coming up around the same topic, but I think there's lots of room to talk about it endlessly. If we can make FACE the department that deals with pain properly, we've achieved something. Yeah, thank you.
Thanks, everyone.
Bye.
Thanks. Bye.